Diuretics part 3. This video is on thiazide diuretics. Of course, our focus is going to be on distal convoluted tubule or DCT, where these diuretics act, this category, the thiazides, and the NCC transporter to which these thiazides bind and inhibit the transport of sodium chloride. Now, let's first recall from our previous videos that there are many categories of diuretics which act by inhibiting the sodium chloride reabsorption in different segments of a nephron. PCT, 67% of the filtered sodium is reabsorbed from the PCT, and but there is no diuretic at present which can block that sodium reabsorption from the PCT. Now, coming to the loop of Henle, thick ascending limb, loop diuretics act there. Now, in the loop of Henle, thick ascending limb, 25% of the filtered sodium is going to be reabsorbed. So, the loop diuretics have the capacity or potential to block 25% of the filtered sodium chloride, and therefore they are high efficacy or high sealing diuretics. Now, coming to the DCT. Distal convoluted tubule reabsorbs some 5 to 10% of the filtered sodium chloride, and therefore this category, the thiazides, which act on the NCC transporter in the DCT, they have a lower sealing in the sense that only 5 to 10% sodium chloride reabsorption can be blocked by these diuretics, and therefore they exert a certain level of diuretic action. So let's see the action of these diuretics, and before that let's talk about the DCT, the transporters, and the reabsorption of various ions. So as a starting point, the thiazide diuretics and the hydrochlorothiazide, an important member of this group, it acts on the DCT where about 10% of the filtered sodium chloride is reabsorbed. Let's see the physiology of this reabsorption first, and then we will discuss the action of thiazides. Right. Now, in the DCT, after the thick ascending limb comes the DCT, and here in the apical membrane of the DCT, there is a transporter called as NCC transporter, sodium chloride co-transporter. So it transports one sodium, one chloride in a co-transport manner, which means, of course, it is electroneutral transporter. One sodium, one chloride, one cation, one anion. So electroneutral transporter. Remember, compare this with the loop of Henle, where there was NKCC, which was also electroneutral, but it was transporting one sodium, one potassium, two chloride. Of course, we also saw there that it actually does not reabsorb potassium. It only reabsorbs sodium chloride, that is in the thick ascending limb. Here also there is reabsorption of sodium chloride by NCC transporter. So on the apical membrane, there is NCC transporter by which sodium and chloride enter the cell lining the tubule. And then on the basolateral side, a common factor everywhere along the nephron, there is sodium-potassium pump. Sodium-potassium pump removes the sodium from inside the cell and eventually sends it into the blood. That is how sodium is reabsorbed. And chloride, which has entered the cell, it has got its own independent transporter. Chloride will also enter the cell via enter the blood via basolateral membrane. So that's how sodium chloride is reabsorbed. Now, how is it different compared to the thick ascending limb? Well, we saw in the case of thick ascending limb of loop of Henle, there was potassium recycling. Potassium was entering the cell, but there was a back diffusion. Potassium would come back, and that potassium coming back into the lumen was creating a lumen positive potential, positive charges will accumulating in the tubule, and because of which calcium and magnesium were driven out of the tubule by the electrochemical gradient. So calcium and magnesium were being absorbed from that segment, the thick ascending limb, by the use of electrochemical gradient. There is no such case happening here because there is no potassium recycling. However, calcium can be reabsorbed by this segment by active reabsorption of the calcium. How it happens? Calcium in the tubular fluids enters the cell via a channel, calcium channel in the apical membrane, and then the calcium leaves the cell from the basolateral side. It leaves the cell to enter the blood by using NCX, sodium calcium exchanger. Remember, this exchanger is also present in the myocardium, myocardial fiber. So anyways, the NCX causes calcium to go out of the cell and sodium is brought into the cell, sodium calcium exchanger, and in this manner calcium is reabsorbed. If you recall, we talked about a thick ascending limb where loop diuretics act. They dissipate that positive electrical potential in the lumen, and therefore they stop the calcium and magnesium reabsorption. So calcium and magnesium, there is a possibility of calcium and magnesium being lost into the urine in the case of loop diuretics. I suggest all of you to refer to that video as well, so that you can recall these things. Well, calcium, if it cannot be reabsorbed from the thick ascending limb, if you have given loop diuretics, there is still a possibility of calcium reabsorption from the DCT because we have this mechanism available in the DCT. So calcium reabsorption very much takes place in the DCT by this mechanism. Let's now see some more details. There is no potassium recycling over here, which was happening in the thick ascending limb of loop of Henle, and therefore there is no lumen positive potential, right? So calcium and magnesium are not driven out by electrochemical gradient in this particular part, in the DCT, all right? And yet, as I mentioned just now, there is active reabsorption of calcium by these two transporters. Calcium enters the cell by channel in the apical membrane, and then NCX will send the calcium out of the cell and reaching the blood. Here, this calcium reabsorption is under the influence of parathyroid hormone. We all know that the parathyroid hormone increases the calcium levels in the plasma by acting on the bone and by acting in the kidney over here. So here is the action of PTH. There is a PTH receptor in the distal convoluted tubule. So it allows the PTH action and it controls this calcium reabsorption. It increases the calcium reabsorption from the distal convoluted tubule, and it also causes phosphaturia. Phosphates are lost into the urine under the influence of PTH. So that is the physiology involved in the ionic reabsorption, particularly of sodium chloride and calcium. Now let's go ahead further and talk about the thiazide diuretics. They inhibit sodium chloride reabsorption from the DCT. We have already seen that. I reiterate the fact, many of the diuretics, they act by inhibiting the sodium chloride reabsorption, and the efficacy of a diuretic will depend on how much sodium chloride is being reabsorbed by that particular segment, because the diuretic is acting on that segment, and if it prevents all the sodium chloride reabsorption from that particular segment, how much efficacy will be there? More the sodium chloride reabsorption being blocked by a diuretic, more efficacious will it be. And we also talked about how a sodium chloride reabsorption being blocked means sodium chloride delivered to the distal parts of the nephron, and sodium reabsorption load will increase for the distal segments, and there will be natriuresis eventually, sodium loss, and therefore water output increases into the urine. This same way thiazide diuretics also act by causing certain amount of natriuresis and diuresis, but their action was to prevent sodium chloride reabsorption in the DCT. Some members of this group, they also possess carbonic anhydrase inhibiting activity. This is just as a matter of fact that some of them, they do have this enzyme inhibitory activity. How does the thiazide diuretic reach its target site of action? Thiazides are secreted into the PCT by organic acid secretory systems. Well, same was the case with loop diuretics. If you remember, in the video we had explained this part. PCT, its middle portion, the S2 segment in the PCT, it has these organic acid secretory systems. Now these secretory systems, they can secrete various organic acids or other solutes. For example, they secrete uric acid, they secrete diuretics, they secrete NSAIDs, they secrete antibiotics like penicillin. So what you should understand, 2 points in this context. One, that the diuretic, the loop diuretic, as well as this thiazide diuretic, they are secreted into the lumen. They flow down the tubular fluid, they flow in the tubular fluid, and they reach the site of action from the luminal side. I have mentioned this in the loop diuretics also, that generally all other drugs, how they reach the target site is that when the drug is given, it goes into the blood, and via blood it is distributed throughout the body and reaches the target site of action. These are unique, whether loop diuretic or thiazide diuretic. They are secreted into the tubular fluid, then via tubular fluid they reach their target site of action. So obviously this is quite understandable, because this NCC transporter, which is being inhibited by the thiazides, it is in the apical membrane facing the lumen. So it's always quite a beneficial thing that this diuretic, it reaches via tubular fluids, the apical membrane is reached, and then the transporter can be blocked. So NCC transporter blocked in the apical membrane by the thiazide diuretics. All right, inhibit the sodium chloride transport and sodium chloride reabsorption from the DCT. We saw that already, and also the fact that secreted into the PCT by organic acid secretory systems. Just one more fact to be highlighted here is that if there is a concurrent administration of diuretics, either loop diuretics or thiazide diuretics, along with one of them concurrently, if antibiotics or NSAIDs are given, then their action will get limited, because let's say if NSAIDs are given along with the thiazide diuretics or NSAIDs with loop diuretics, these two, means NSAIDs and the thiazides, they will compete for the same transport system, which we mentioned as organic acid secretory system, and therefore due to this competition, less of the diuretic will get secreted, less of the diuretic will reach the its site of action, and therefore its efficacy will be limited. So that's one more point to be highlighted. Concurrent administration of diuretics and NSAIDs or diuretics and antibiotics will reduce the overall efficacy of the diuretic because of this competition to bind with the transport system. All right. So with that in mind, let's also see just a comparison between loop diuretics and thiazide diuretics in the context of calcium reabsorption. a very important point to be remembered here is that thiazides enhance the calcium reabsorption. A very important differentiating feature between thiazide diuretics and loop diuretics. Remember, loop diuretics, they decrease the calcium reabsorption from the thick ascending limb. And why was that? Because as we mentioned some time back, that they block the NKCC transporter, the loop diuretics. If that is blocked, the potassium recycling is also blocked. So potassium does not come into the tubule domain. And because of that, that electrical gradient which is established normally will not get established. So there is no electrochemical driving force for calcium and magnesium reabsorption in the loop of Henle when you give loop diuretics. So loop diuretics prevent the calcium and magnesium reabsorption. We saw that in the previous video. However, the thiazides, they actually enhance the calcium reabsorption. How? Let's check it out here. NCC transporter. Now when you give thiazides, they bind with the NCC transporter, which means what? Which means sodium chloride reabsorption will decrease. Sodium reabsorption decreases means sodium entry into the cell, the lining cell. Sodium entry into the cell is decreased, which means what? Which means sodium concentration inside the cell will fall. And if the sodium concentration inside the cell decreases, then it becomes a driving force for the NCX, because the NCX is going to cause sodium to come into the cell from the basolateral side. So if the sodium concentration is less inside, that means there is a greater concentration gradient for sodium from outside to inside. That means the NCX activity will enhance. So enhanced activity means sodium will come in and calcium will be driven out from via the basolateral membrane. And since that happens, calcium reabsorption will increase. So this is quite a differentiating feature between loop diuretics and thiazide diuretics. Loop diuretics, they decrease the calcium reabsorption. Thiazides, they increase the calcium reabsorption by increasing the activity of NCX, which is a fallout of binding to the NCC transporter. Right. So sodium inside the cell decreases, therefore enhance NCX activity and therefore increased calcium reabsorption. So that's an important distinguishing feature, and therefore these diuretics are useful in the treatment of renal stones caused by hypercalciuria. Yes, if there are certain factors which are causing hypercalciuria and therefore resulting in renal stones, thiazides can prevent this by increasing the calcium reabsorption. So there is no increased amount of calcium being excreted into the urine, and therefore this particular condition can be prevented by the thiazide diuretics. All right. Now let us see the remaining part of the story. Indications and toxicity of the thiazides. In any condition where you need to decrease the circulating blood volume, thiazides can be given. Obviously, they cause diuresis and therefore they will be useful in such conditions. So hypertension, heart failure, nephrolithiasis, as I mentioned just now, nephrolithiasis resulting from hypercalciuria can be treated by thiazide diuretics because they increase the calcium reabsorption. They prevent the calcium loss into the urine. Okay. Well, one more highlight. Thiazide diuretics can be given in nephrogenic diabetes insipidus. Now this is an apparent paradox. It's quite paradoxical, isn't it? Because these are diuretics. They are going to increase the urine output. Diuresis is increased urine flow, increased urine output. Whereas, what is nephrogenic diabetes insipidus? ADH cannot act on the kidney to cause water reabsorption. That means urine output increases in diabetes insipidus. So here we are saying that diabetes insipidus has increased urine output, and you can treat it by giving thiazide diuretics, which are known to increase the urine output. This appears quite paradoxical. I mean, to our mind, it might further increase urine output. No, it actually acts in the other way fashion. Let's see why. Let's see how. Thiazides, they decrease the plasma volume, and that's the mainstay of this particular effect, their effect in the diabetes insipidus. They decrease the circulating plasma, they decrease the plasma volume, and therefore the renal blood flow and renal plasma flow will also decrease, obviously. That means GFR also decreases. Now, in the conditions of decreased GFR, there is increased sodium chloride reabsorption by the PCT. Because already the circulating volume is less, therefore PCT will have a tendency of increased sodium chloride and water reabsorption. Yes, and therefore the fluid delivery to the later distant part of the nephron will become less and less. It's the PCT which will tend to increase the reabsorption of sodium chloride and water. So less sodium chloride and therefore less fluid will be delivered to the loop of Henle and to the collecting duct. So the resultant condition is that maximum amount of dilute urine that could be produced in the diabetes insipidus, that is it becomes less. How much can be the maximum dilute urine that can be produced in diabetes insipidus? That volume becomes less, because less and less fluid volume is reaching the distal segments of the nephron, and therefore overall the maximum amount of dilute urine that could be generated due to diabetes insipidus, that will be less, and that's how thiazides can be useful in the conditions of nephrogenic diabetes insipidus or drug-induced diabetes insipidus. You know, lithium is a drug given in manic depressive disorders, and it has a tendency to produce cause diabetes insipidus. So in such conditions, thiazides can be useful. Finally, the toxicity, hypokalemic metabolic alkalosis. This is common. Loop diuretics and thiazides, they both show this side effect. Hypokalemia, this is common. You know, in the previous video we have discussed this, that many diuretic categories, they cause potassium loss into the urine, hypokalemia results, and therefore there was a need for another category, that is potassium sparing diuretics, which will not cause potassium loss. So anyways, here hypokalemia and alkalosis. So we saw this in the loop diuretics, that intercalated cell in the kidney, it reabsorbs potassium and secretes H+. So if there is more load of sodium for reabsorption in the collecting duct, more potassium will be secreted, more potassium will have to be reabsorbed, that will be the load, increased load, and therefore more H+ will be secreted. We have seen all of this in the loop diuretics. Hyperuricemia, yes. Look, thiazides and uric acid, they both compete for that same organic acid secretory system in the PCT, and due to this competition, the uric acid secretion in the PCT will reduce if thiazides are binding to the same carriers. That means uric acid levels in the plasma will increase, because its secretion and excretion has been affected by thiazide diuretics. Impaired glucose tolerance, yes, with thiazides this one particular side effect has been mentioned, that they decrease the insulin secretion as well as they decrease the insulin sensitivity. So they are shown to be hyperglycemic and to be used in with caution in the diabetic patients. Dilutional hyponatremia, yes, this one peculiar side effect has been seen. Why it happens? Because thiazides decrease the circulating plasma volume, and as a result of that, there is increased release of ADH, and increased ADH will eventually cause increased conservation of water. This is a side effect. Okay, increased conservation of water on one hand and loss of sodium on the other hand. So this results in hyponatremia, and because it's a sodium less in comparison to water which has increased due to ADH, it's dilutional hyponatremia. So these are the side effects or toxicity caused by thiazide diuretics. Finally, it's just a comparative table to understand what are the similarities and what are the differences. So loop diuretics decrease sodium chloride reabsorption. Thiazide diuretics, same mechanism of action. Of course, loop diuretics can decrease 25% sodium chloride reabsorption. So they are high efficacious, high ceiling diuretics. Thiazides can decrease only 10% sodium chloride reabsorption, which is happening from the DCT. So low efficacy or low ceiling. All right. Transporter which is inhibited, NKCC transporter in the case of loop diuretics, NCC transporter in the case of thiazides. Delivered from the luminal side, yes, delivered in the PCT first, and then in the tubular fluids they travel to the site where they are going to act. That's the same for both these diuretics. Finally, decreased calcium reabsorption, loop diuretics. Increased calcium reabsorption, thiazide diuretics. That's a key difference between the two. So although they are preventing sodium chloride reabsorption and thereby causing natriuresis and diuresis, that part is same, but because of their actions on various transporters and various ion transports, therefore this becomes a differentiating feature. So that was about the thiazide diuretics. In the remaining videos, we will discuss the potassium sparing diuretics and osmotic diuretics and the remaining types of diuretics.